Welcome back to the deep dive. Today we are taking on a true crucible of acute care, traumatic brain injury or TBI.
It's a huge topic and one that's, absolutely critical for anyone in acute medicine.
Absolutely. We have distilled a powerhouse of knowledge for you, specifically Chapter 28 of Bailey and Love's Short Practice of Surgery, to give you a really detailed, structured, and actionable understanding of this field.
And our mission, I think, is pretty simple.
It is. We want to transform these dense surgical principles into clear, high-yield knowledge. We're going to navigate TBI management from the ground up.
Starting with that fundamental, almost mathematical physiology that governs blood flow in the brain.
Exactly. Then moving through the crucial assessment protocols, things like the NICE guidelines, the GCS, and then right up to the specifics of ICU management and surgical pathology.
I mean, this isn't just about reading the chapter.
No, it's about making sure you can retrieve and apply every single crucial fact when seconds literally count.
And the clinical weight of this topic, it just can't be overstated. TBI is a massive global health crisis.
The numbers are pretty staggering, aren't they?
They are. If you look at the UK data cited in our sources, it accounts for 3 to 4% of all emergency department attendances.
3 to 4%, so what does that break down to?
It's roughly 1,500 cases per 100,000 population every single year. The volume is just immense.
And that volume is one thing, but the impact is even more severe when you look at who this is affecting.
Exactly. TBI is the leading cause of death and disability for an enormous chunk of the population. We're talking from childhood right through to early middle age.
So these are devastating, life-altering injuries to people at the absolute peak of their life.
Their professional lives, their family life, all of it.
And the mechanism behind it all tells a predictable yet pretty grim story.
Road traffic accidents.
Yeah.
RTAs, they're the dominant cause, accounting for up to 50% of severe TBI cases.
So when we approach a patient with a TBI, the entire clinical strategy really hinges on understanding the time component, doesn't it?
It's all about time. You have the primary injury. That's the initial structural damage that happens on impact.
The moment of the crash or the fall.
Exactly. And that is, for all intents and purposes, unmodifiable. It's done. But then you have the secondary injury.
And this is the critical window, right? This is where we can actually make a difference.
It's the only thing we can control. The secondary injury is this insidious cascade of subsequent damage. Swelling, ischemia, inflammation, cellular death.
And this all progresses in the hours and days after the initial trauma.
Precisely. And the difference between a poor outcome and a good recovery often lies entirely in our ability to mitigate the secondary phase.
And at the heart of controlling that secondary injury, the ischemia and swelling, is the aggressive regulation of pressure inside the skull.
Intracranial pressure, or ICP. We have to essentially substitute the brain's natural defenses, which have been shattered by the trauma.
Okay, so let's start with those physiological foundations, because getting the maths here literally saves lives. The brain, it's an extraordinarily high-demand organ.
It's totally dependent on continuous high-flow perfusion for all of its metabolic needs, oxygen and glucose.
And unlike other organs, it can't really store these resources, can it?
It has almost no capacity to store them. Normal cerebral blood flow, or CBF, is about 55 milliliters per minute for every 100 grams of brain tissue.
Okay, so that's the normal operating rate. But what happens under stress? What's that critical threshold we're fighting to stay above?
The threshold for severe danger is 20 mmN per 100 gram. That's the number to remember.
20.
When flow drops below that point, you get ischemia. The tissue starts to suffocate. If that flow drops even lower or stays at that low level for too long, you rapidly get cell death, infarction.
So if we can't deliver that flow, the patient loses functional brain tissue, and that leads directly to disability or death.
Exactly. And to guarantee that flow, we have to focus on the pressure that drives it. And that brings us to the classic equation.
Cerebral perfusion pressure.
CPP. It's the defining metric. It's simply the difference between the pressure driving blood into the brain, your mean arterial pressure, or MAP,
and the pressure opposing it, which is the intracranial pressure, the ICP.
So CPP equals MAP minus ICP. Simple as that.
And if we look at the typical physiological ranges, you can see why this is such a delicate balance.
Well, a normal CPP is somewhere between 75 and 105 millimillar Hg. That's achieved with a systemic MAP, usually around 90 to 110 millimillar Hg.
And that's battling an ICP that should be really low.
Right, only about 5 to 15 millimillar Hg. But you can see the problem. If your ICP shoots up to, say, 30 and your systemic pressure is only 90,
your CPP is immediately cut in half, from 75 down to 60.
and you're heading straight for ischemia. It's a mathematical certainty.
And ordinarily, the healthy brain is protected from these sorts of systemic fluctuations by a really magnificent mechanism.
Cerebral autoregulation. It's
It-
beautiful, really.
Explain that mechanism, because its failure is absolutely central to trauma management.
Cerebral autoregulation is the brain's intrinsic ability to adjust the diameter of its own blood vessels. They constrict or dilate to maintain CBF at a remarkably constant level.
Even if the systemic blood pressure is swinging wildly.
Exactly. Even if the MAP is swinging between, say, 50 and 150 millimole Hg, which is a huge range, the vessels sense that change and adjust their own resistance to keep flow steady.
But in a severely traumatized brain, that protection is just gone.
It's gone. Autoregulation is often impaired or totally lost after TBI. This means the cerebral blood flow becomes, and this is a key term, pressure passive.
So what does that mean in practice?
It means the brain is at the mercy of systemic pressures. If the MAP drops slightly because the patient has lost blood elsewhere,
CBF plummets.
and if the ICP rises from swelling,
CBF also plummets.
exactly. This is why in the neuro ICU setting, we can no longer rely on the body to handle things. We have to aggressively and actively regulate MAP and ICP within very tight windows to prevent that catastrophic secondary injury. Hashtag tag 1.2, the Monroe-Kelly doctrine, and herniation syndromes.
Now, all of this pressure regulation happens within a very strict physical constraint, and that's defined by the Monroe-Kelly doctrine.
Named for the 18th and 19th century anatomists Alexander Monroe and George Kelly.
And the premise is really simple. The cranium is a rigid, non-compliant box.
That's it. Inside that rigid box, you've got three things: brain tissue, blood, both arterial and venous, and cerebrospinal fluid, or CSF. The total volume is fixed.
So if you increase the volume of one of those components, say you add a new hematoma or the brain starts to swell,
You got a problem. Something has to give.
we call the initial handling of this volume increase the compensation phase. So how does the brain buy itself some time?
Well, the brain accommodates that new volume by displacing the most pliable components first. That's the venous blood and the CSF.
So it can squeeze venous blood out of the intracranial sinuses?
Yep, and it can push CSF down into the spinal subarachnoid space. This mechanism keeps the ICP relatively stable at first, even as that lesion is growing.
But here's where the physics turns against you, the moment of decompensation.
Once every last drop of displaceable fluid is gone, the game completely changes. Any further increase in volume, even a tiny amount,
Causes a huge spike in ICP.
an exponential rise. The pressure curve just goes vertical. Yeah. And this uncontrolled rise in pressure inevitably forces brain tissue to shift.
It moves from areas of high pressure to lower pressure zones.
And that results in herniation.
And herniation is a catastrophic physiological event that demands immediate recognition. Let's detail the two critical syndromes you absolutely have to know cold. First, uncle herniation.
Uncle herniation is essentially a lateral or sideways shift. The uncus, that's the innermost part of the temporal lobe, is forced medially over the edge of the tentorium cerebelli.
And what's the first victim of that shift?
The third cranial nerve, the oculomotor nerve, which runs right along that path.
So what's the clinical consequence? What does a nurse or a doctor at the bedside see first?
Well, the parasympathetic fibers that are responsible for constricting the pupil, they run along the surface of that third nerve, so they're the most susceptible to compression.
They get squeezed first.
Exactly. When they get squeezed, the sympathetic supply to the pupil goes unopposed. And clinically what you see is, first, an ipsilateral pupil, so same side as the lesion, that becomes sluggishly enlarged,
And then it progresses rapidly.
to being fixed and fully dilated. This is the telltale sign of imminent or already occurring herniation.
Okay, and the second one, which is a sign of complete collapse, is tonsillar herniation. We also call it coning.
This is the final disastrous downward displacement. The cerebellar tonsils are forced down through the foramen magnum.
The big hole at the base of the skull.
Right, and this directly compresses the medullary centers in the brainstem, the centers that control the absolute fundamentals of survival, vasomotor and respiratory function.
And this compression is what leads to that classic pattern named after Dr. Harvey Cushing.
The Cushing's triad. When you see this, the patient is actively coning, and you have moments, not hours.
What are the three components of the triad?
First, hypertension, and often a dramatically high blood pressure. Second, a reflex bradycardia, so a paradoxically slow heart rate despite that high pressure.
That's the medullary compromise?
It is. And third, severely irregular respiration. If this is allowed to progress, it results in rapid brainstem death. We have to reverse this process immediately.
All right, moving from the physiology of impending disaster to the nuts and bolts of assessment. Everything begins with the Glasgow Coma Scale, or GCS.
It is the single most important tool in head injury assessment. You can't overstate its importance.
Why is it so fundamental?
Because the GCS score, when you take it after the initial resuscitation is done, is the best predictor of neurological outcome. Full stop. You need to know which category your patient falls into to guide your triage and management.
So let's clearly define those 4 categories based on that post-resuscitation GCS score.
Okay. First, minor head injury. This is defined as a GCS of 15 with no loss of consciousness, or LOC.
GCS 15, no LOC.
Got it. Then you have mild head injury. This is a GCS of 14 or 15, but with a documented LOC at the time of the injury.
Okay, so the LOC is the key differentiator there.
Exactly. Then we get more serious. Moderate head injury is a GCS from 9 to 13.
And finally, severe.
Anything with a GCS of 3 to 8 is classified as a severe head injury.
Now, there's a critical caveat here, isn't there?
Always. You have to recognize that coexisting factors like alcohol intoxication or drug use can artificially suppress the GCS score.
So it can make the injury look worse than it is or mask a serious injury under the effects of the substance.
It complicates your initial assessment of severity, absolutely. Hashtag tag 2.2 triage and discharge criteria for minor mild injury.
So for the vast majority of patients, those in that minor or mild category, the big decision is whether to observe them or discharge them safely.
And this decision is completely haunted by the possibility of the lucid interval.
Ah, the classic talk and die scenario.
It's an early warning system that was missed. The patient suffers the initial trauma, seems to recover completely, is talking, seems fine, and then rapidly crashes as an intracranial hematoma expands in the background.
And that's typically an extradural hematoma, an EDH.
Usually, yes. And our discharge criteria are designed precisely to prevent us from sending someone home who is about to enter that rapid deterioration phase.
The UK NINES guidelines provide the gold standard for these discharge criteria. If a patient is going home, they have to meet all of these points.
And the criteria are pretty exhaustive, as they should be. You need a GCS of 15 with absolutely no focal neurological deficits.
None at all.
If they required any imaging, that CT scan has to be completely normal. They can't be under the influence of drugs or alcohol, which might mask a decline later on.
And they can't go home alone.
No. They must be accompanied by a responsible adult who can monitor them overnight. And, maybe most importantly, they have to be given comprehensive, clear, verbal, and written head injury advice.
So what are the absolute red flags that responsible adult needs to be looking for?
Persistent vomiting.
Yep.
So more than just a single episode, a worsening headache that doesn't get better with simple pain relief.
What about consciousness?
Increasing drowsiness or any difficulty in arousing the patient. Also, any visual disturbance or any new weakness or numbness in a limb.
And if any of those symptoms arise,
They have to return to the emergency department immediately. No delay. Hashtag check 2.3 indications for CT imaging. Nice guidelines.
okay, so for anyone who doesn't meet those discharge criteria or who presents with other high-risk factors, imaging is required.
And the NEET guidelines are very strict. They define 2 tiers of urgency for CT scanning.
Let's start with the most urgent, CT within 1 hour. Who falls into that category?
These are the patients who are closest to a catastrophe. The criteria mandating an immediate scan are, first, a GCS score of less than 13 at any point since the trauma.
So they're already in that moderate or severe category.
Exactly. Second, a GCS that is less than 15 2 hours after the injury. This signals that they're failing to recover rapidly.
Okay, what else?
Any focal neurological deficit found on examination. Any suspicion of a fracture that has breached the defenses so, an open depressed, or a basal skull fracture.
And then there are 2 more that are about symptoms rather than GCS score.
Right. More than 1 episode of vomiting, or any post-traumatic seizure.
It's interesting that the seizure and vomiting criteria don't require a low GCS, but they're still immediate red flags. They're proxies for elevated ICP.
That's exactly it. They suggest rapidly increasing intracranial pressure or significant parenchymal irritation, regardless of what the patient's current GCS is.
Okay, so that's the immediate tier. What about the second tier, imaging required within 8 hours?
These are patients at a higher risk, but not necessarily facing that imminent deterioration.
Who's on this list?
This includes anyone over the age of 65 because brain atrophy increases the risk of those bridging veins tearing.
Anyone with a clotting problem.
Any known coagulopathy. So if the patient is on blood thinners like aspirin, clopidogrel, or warfarin, also a dangerous mechanism of injury.
Like being thrown from a car or a fall from a height.
Exactly. Or, finally, prolonged retrograde amnesia, which is defined as being unable to remember events for more than 30 minutes before the injury. That suggests a really severe energy transfer event.
So the systematic approach, it really helps allocate resources and focus attention. It's a roadmap for risk.
It is. It takes the guesswork out of it. Hashtag 2.4 concussion and post-concussive syndromes.
Let's shift to the mild end of the spectrum for a moment.
Right.
Concussion. It's a clinical diagnosis, right? Often without any obvious pathology on an initial scan.
It is. Concussion is formally defined as an alteration of consciousness resulting from a closed head injury. And crucially, the source material confirms that loss of consciousness is not required for the diagnosis.
So what are the key features you're looking for?
Transient confusion, amnesia, emotional ability, lethargy, or just that feeling of being foggy or out of it.
And the primary message here, particularly in the world of sports medicine, concerns something called second impact syndrome, or SIS. It's rare, but it's devastating.
SIS occurs when an individual suffers a second head injury while they are still symptomatic from the first one.
So their brain hasn't healed yet.
Their cerebral vessels are still damaged, and their autoregulation is disordered. That second impact, which can be apparently trivial, triggers this uncontrolled malignant brain swelling.
And the outcome.
It leads rapidly to coma and often death. The advice is absolute. If you are symptomatic, you do not return to play, period.
And then there's the chronic consequence, post-concussive syndrome. This seems like a really challenging diagnosis because the symptoms are so diverse and subjective.
It is. It's a constellation of symptoms that can persist for months or even years. Patients commonly report persistent headaches, chronic dizziness, fatigue.
And cognitive issues.
Right, neurocognitive issues. Difficulty concentrating, impaired memory, anxiety, depression, significant emotional changes. It can be really debilitating.
I know the source material touches on the complicating factor of secondary gain. How do clinicians navigate that tension between validating a patient's very real suffering and accounting for the possibility of external factors influencing how they report their symptoms?
It's a genuine challenge. You have to validate the patient's experience. Most patients with persistent symptoms are genuinely suffering. But at the same time, clinicians have to maintain objectivity and consider if the persistence or, say, exaggeration of symptoms might be influenced by things like litigation or compensation processes.
So it demands a really sensitive approach.
A very sensitive multidisciplinary approach to both the diagnosis and the long-term rehabilitation.
We are now moving into the critical zone, moderate and severe TBI. These are unstable patients who require immediate organized care based on advanced trauma life support, or ATLS protocols.
Absolutely. The ABC's airway, breathing, and circulation govern the initial approach, with rigid C-spine control until it's been excluded.
But for the brain specifically, what's the fundamental priority?
Ensuring there is uninterrupted perfusion of oxygenated blood. Hypoxia and hypotension are the twin pillars of secondary brain injury. We cannot fix the initial injury, but we must fix the physiology. Hashtag 3.1 resuscitation in history.
So while that resuscitation is happening, getting the history is critical, and you're often getting it from paramedics or witnesses. What are the key elements you have to extract quickly?
Okay, first, the mechanism of injury. Was it high energy? Because that demands a high index of suspicion for other associated multisystem injuries, especially spinal fractures.
Second, the sequence of events.
Exactly. Was there a primary medical event that caused the fall or the accident? Did they have a seizure, a cardiac arrhythmia, or were they hypoglycemic? We need to know this to prevent it from happening again.
And third, the progression of their consciousness.
Yes. What was the GCS at the scene versus on arrival? Is it getting better, worse, or staying the same? That trajectory is vital.
And their medication history, specifically their coagulation status, that's paramount if we even suspect there might be an operable lesion.
If a patient is on an anticoagulant or an antiplatelet agent, we have to know immediately. It significantly complicates surgical planning and affects the rate at which any hematoma might expand.
So you might need to reverse them.
Reversal may need to happen even before you get them to the scanner, based on clinical suspicion, especially if the patient is deteriorating rapidly in front of you.
Within that primary survey, there are specific neurological checks that just cannot wait.
Right. So beyond ensuring you've got adequate oxygenation and circulation, you have to perform those essential neuro checks.
Yeah.
Pupils, GCS, and look for any gross focal deficits.
But there's one really simple, quick, and critical reversible cause you have to exclude.
Hypoglycemia. If the patient is obtunded, a blood sugar check is absolutely mandatory.
Because giving dextrose can reverse a coma.
It can rapidly reverse a coma and prevent devastating ischemic injury. And it doesn't cause any harm if their sugar turns out to be normal. It's a no-brainer.
Let's revisit the pupils. Why is the change in pupil size such a sensitive and frankly terrifying indicator of impending doom?
Because of the precise anatomy of uncal herniation that we talked about. The fixed dilated pupil is the direct clinical sign of that third nerve being compressed.
It's the parasympathetic fibers getting squeezed.
They're on the outside of the nerve, so they get hit first. The sympathetic system is then left unopposed, and that causes maximal fixed dilation. It tells you that brainstem compromise is already underway.
And what if you can't see the pupils? Maybe due to swelling or a direct eye trauma? Or what if the patient has a pre-existing issue?
Well, if there's trauma to the eye itself, or a pre-existing condition like a Holmes 80 pupil, then that sign is obscured. But in the absence of obvious ocular trauma, a new unilateral fixed and dilated pupil in a trauma setting.
Is herniation until proven otherwise?
It is, and it mandates immediate action. That often means giving hyperosmolar therapy right there or getting them to the CT scanner immediately. Tech 3.3 Glasgow Coma Scale GCS breakdown.
It's so vital we stress this. You should never, ever record just the sum score of the GCS.
That is a fundamental clinical requirement. You have to record the three components, I, verbal V, and motor M.
Why is that so important?
Because a GCS of, say, 8 out of 15 might hide very different pathologies. It depends on whether their motor score is 5, meaning they're localizing to pain, or 1, meaning they have no response at all.
So the components tell us which parts of the brain are compromised.
While the sum only gives you the overall level of consciousness, the motor score in particular is the most prognostic component.
So give us a quick refresher on the key scoring categories.
Sure. Eye-opening, E, is from 4 for spontaneous down to 1 for no response. Verbal response, V, is 5 for orientated down to 1 for no sounds. And we use T if they're intubated.
And the motor response, M, the most important one.
Right. M6 is for obeying commands, all the way down to M1 for no motor response.
And what's the rule for applying a painful stimulus? How do we make sure we get the best performance possible, and what stimulus is appropriate?
You have to use an appropriate, usually central, painful stimulus. Things like a sternal rub, supraorbital pressure, or a trapezius squeeze. And crucially, you must always record the best motor performance elicited.
So if one side is better than the other?
You score the better side. If the right side localizes to pain, which is an M5, but the left side only withdraws, an M4, the overall score is M5, this ensures you're not penalized for a unilateral injury.
Okay, once the patient is stabilized, the secondary survey is that meticulous head-to-toe search for all the coexisting injuries.
And the head, neck, and spine examination is absolutely critical. We have to inspect and palpate the entire head, looking for lacerations and significantly subgaleal hematomas.
These might seem benign, but they can be a big deal, especially in kids.
A huge deal. They can be very large and cause substantial ongoing blood loss. The focus then shifts to finding the signs of a basal skull fracture.
And these signs are often delayed and can be quite subtle. What are the specific bruising patterns we're looking for?
The classics are battle sign. That's bruising over the mastoid process behind the ear, and raccoon, or panda eyes, which is bilateral bruising around the orbits.
And you also have to check for any fluid leaks.
Yes, you look for hemotympanum, which is blood behind the eardrum, or critically, CSF rhinorrhea or otorrhea. That's a clear fluid leak from the nose or the ear.
And a persistent CSF leak is a big risk for meningitis, right?
A very high risk of ascending meningitis, yes.
The link between TBI and spinal injury is incredibly high. We cannot afford to miss this.
The incidence of cervical spine fracture in moderate to severe TBI is up to 10%. The rule is simple. Until it is radiologically and clinically excluded, a C-spine injury must be presumed.
So the patient stays in a hard collar.
They stay in a hard collar. And the clearance process isn't simple. Even a clean CT scan might miss a ligamentous injury, which means collar management has to continue until definitive clearance is possible.
And the final piece of the secondary survey, the log roll and the perectum examination.
The patient has to be log rolled so you can palpate the entire spine, feeling for any steps, tenderness, or deformity.
And the perectum exam is mandatory.
It is. You're assessing anal tone and the anal wink reflex. If the patient has a severe spinal cord injury, you may see a loss of tone.
And conversely, in male patients.
In male patients, priapism, which is a sustained erection, is a strong and immediate predictor of a severe spinal cord injury. It's due to the disruption of those autonomic pathways.
All right, let's move to the visible damage, what we actually see on the CT scans, and really understand the critical differences between the types of intracranial pathology.
We categorize these injuries based on their location and their mechanism, and we can start with fractures, which are basically the footprint of the trauma. Hashtag 4.1 skull fractures.
So simple linear fractures of the skull vault are usually stable, but depressed fractures carry a high risk and often need surgery.
A depressed skull fracture is one where the bone fragment is displaced inward by at least the thickness of the skull itself.
And why are these so high risk?
Because they're often associated with a tear in the dura mater, the lining of the brain. That significantly increases the risk of infection and, in the long term, epilepsy.
So they require surgical intervention.
They require surgical elevation and debridement, especially if there's any intracranial error visible on the CT, because that confirms a dural breach.
The skull-base fractures we talked about earlier, they have their own unique set of complications.
They do. Beyond the acute signs, the long-term complications can be severe. Things like cranial nerve deficits, losing your sense of smell, a facial palsy pituitary dysfunction, or even an arterial dissection that leads to a delayed stroke.
And a persistent CSF leak always needs follow-up.
Always. It may require surgical repair to mitigate that very real risk of meningitis.
And we absolutely must reiterate the critical contraindication related to basal fractures.
Yes. Blind nasogastric tube placement is absolutely contraindicated. If a basal skull fracture exists, especially a cribriform plate fracture, that tube can pass intracranially.
With potentially fatal consequences.
Absolutely fatal. Hashtag 4.2 extradural hematoma.
EDH. Now, extradural hematoma, this is the quintessential neurosurgical emergency. It often provides the best prognosis if you catch it immediately.
The mechanism is typically a tear in an artery. Classically, it's the middle meningeal artery, and it's often caused by a fracture of the thin squamous temporal bone.
So the bleeding is between the bone and the dura mater.
Right. And because it's arterial, it expands very, very rapidly.
And this is the famous pathology that's associated with the lucid interval.
The classic presentation, which happens in about a third of cases, that talk and die phenomenon, is a transient LOC on impact, followed by a period where the patient is awake, talking, and seems completely fine.
The lucid interval.
Exactly. And as that arterial blood accumulates, it exhausts all the compensatory mechanisms, and that leads to a rapid catastrophic deterioration.
A fixed pupil, hemiparesis, coma.
The whole cascade.
So how does this look distinctively on a CT scan?
Because the dura mater is so tightly stuck to the skull at the suture lines, the blood is restricted laterally. It can't spread out, so it pushes inward.
Creating a very specific shape.
A characteristic lentiform or biconvex shape. It looks like a magnifying glass or a lens. Yeah. A hyperdense, bright white collection sitting flush against the inner table of the skull.
And the management is?
Immediate surgical evacuation, no question. Hashtag 4.3. Acute subdural hematoma, ASH.
In stark contrast, an acute subdural hematoma, or ASH, carries a much, much darker prognosis. Why is an ASH so often more deadly than an EDH?
Because an ASH is usually associated with significant underlying primary brain injury. We're talking about contusions, edema, parenchymal damage.
So it's not just the blood, it's the brain underneath that's badly hurt.
Exactly. It's caused by a high-energy mechanism that tears the breathing veins or the cortical vessels. The patient often deteriorates immediately, without any lucid interval. They're suffering the consequences of the blood and the smashed brain tissue underneath.
And while it can also happen in older patients from lower energy trauma, the prognosis is still often dictated by that underlying injury.
It is, regardless of how quickly we drain the blood.
And the visual distinction on the CT is key for a rapid diagnosis.
Subdural blood collects under the dura. And since the dura isn't adherent to the brain surface itself, the blood collection is free to spread across the entire hemisphere.
So it looks different from an EDH.
Completely different. It results in a distinctive diffuse concave or crescent-shaped appearance that conforms to the contour of the brain surface. Hashtag 4.4 chronic subdural hematoma, CSH.
Now, a chronic subdural hematoma presents a very different clinical challenge. It primarily affects the elderly and often presents weeks after what seemed like a trivial incident.
This is a pathology of aging. As the brain shrinks with age cerebral atrophy, the bridging veins that run from the cortex to the dura get stretched taut.
So they're vulnerable.
Very vulnerable. A minor knock, especially if the patient is on anticoagulants, can tear one of these veins. The blood then accumulates very slowly.
And the hematoma itself actually expands over time through osmosis?
Yes, it does. The initial blood breaks down, and the degradation products create a high osmotic gradient, which then draws more fluid into the collection. It becomes a chronic expanding mass.
And it eventually causes symptoms that develop insidiously over weeks.
Things like headache, confusion, gait disturbance, and focal deficits. It can often be mistaken for dementia or stroke.
So what's the appearance on CT that tells us it's chronic and not acute?
Acute blood is hyperdense, so it's bright white on a CT. Chronic blood is degraded, so the collection is typically hypodense. It's darker than the surrounding brain tissue, but it still maintains that diffuse crescent shape.
And what if you see a mix of bright and dark?
If you see areas of bright blood mixed in with the dark fluid, that's what we call an acute on chronic bleed. It indicates a recent rebleed into that old collection.
And the management is quite different.
It is. We reverse their anticoagulation. Drainage is usually performed via burr holes, which is much less invasive than the large craniotomy you need for an acute SDH.
And sometimes you even wait to operate.
In stable patients, there might be a conscious decision to delay surgery for 7 to 10 days to allow the effects of antiplatelet drugs like aspirin to wear off, which makes the subsequent drainage much safer. Hashtag tag 4.5. Other injury patterns.
Beyond those primary bleeds, we need to quickly cover 3 other major injury patterns. First, traumatic subarachnoid hemorrhage, or TSAH.
TSAH is very common. In fact, trauma is the most frequent cause of any subarachnoid hemorrhage. The blood just tracks into the CSF spaces.
But the good news here is that it behaves differently from an aneurysmal SAH.
Right. Unlike an aneurysmal SAH, the traumatic form is generally managed conservatively, and it doesn't carry that high risk of severe delayed vasospasm.
But the clinical presentation can be really confusing.
Absolutely. The headache is often severe. The key diagnostic question you have to ask is, did they have a spontaneous aneurysmal SAH that caused them to collapse and hit their head?
So you have to rule that out.
If there's any doubt at all, you need angiography to check for an underlying aneurysm.
Okay, next up, cerebral contusions. The physical bruising of the brain. Where do they typically happen?
They're most common where the brain meets the rough, bony interfaces inside the skull, so the inferior frontal lobes and the temporal poles.
And the mechanism is coup contre coup.
Exactly. The initial impact causes a contusion at the site of the blow, that's the coup, and then the secondary impact as the brain bounces against the opposite side of the skull causes another contusion there. That's the contre coup.
And on CT, they just look messy.
They're heterogeneous. It's basically smashed brain mixed with acute blood. They rarely require surgical evacuation unless they expand significantly and start causing mass effect.
And finally, diffuse axonal injury, or DAI. This is the most devastating non-mass lesion TBI.
DAI is a primary injury. It happens from extreme acceleration to deceleration, leading to shear forces that physically tear and stretch the axon.
The connecting wires of the brain.
Exactly. And because it disconnects these vast networks, these patients are often comatose from the very moment of impact. It's associated with the worst outcomes.
So if you have a patient who is comatose, but has a relatively unremarkable CT scan, no massive hematoma DAI should be your primary suspicion.
It should.
So how does it manifest on imaging?
Well, it's really a pathological diagnosis, but on CT, we look for small hemorrhagic foci, particularly in the corpus callosum or the dorsolateral brainstem. But crucially, a normal or near-normal CT does not exclude severe DAI.
So what's the better imaging modality?
MRI is far more sensitive for detecting that widespread non-hemorrhagic white matter damage.
So we've identified the enemy, the primary injury, and the mechanism of attack, that secondary injury cascade. Now we turn to the ICU, where the entire focus is on controlling that cycle of swelling and ischemia.
It's a vicious cycle. You have a mass lesion or swelling, which leads to raised ICP, that crushes your CPP, which leads to ischemia. That ischemia causes secondary injury, which then causes further swelling.
And the cycle just accelerates.
It does. Our entire strategy is dedicated to breaking this cycle by maintaining cerebral oxygenation, preventing hypotension, and strictly controlling ICP.
And the data really supports the need for specialized care. Why is it so important that severe TBI patients are transferred quickly to a neurocenter, even if they aren't going to the operating room immediately?
Because the specialized monitoring and the immediate access to neurosurgical expertise is life-saving. The data shows higher mortality for severe TBI managed outside of dedicated neurosurgical centers.
So the NEISS guidelines are clear on this.
They strongly recommend early transfer to ensure that optimal physiologic management can be started, regardless of whether they need acute surgery or not. Hashtag 5.2 controlling intracranial pressure, ICP.
The first, most immediate tool we reach for in a severe TBI is intubation and ventilation.
Airway control is often mandatory for severe TBI, so a GCS of 8 or less. But we also intubate moderate TBI patients to facilitate a safe transfer, manage profound agitation, and most importantly, gain control over their breathing.
Specifically, their PACO2.
Exactly. The level of CO2 in the blood directly influences cerebral vessel tone and therefore ICP.
Okay, so the patient's intubated, but their ICP is spiking rapidly. What are the temporizing pharmacological measures you use to buy a few minutes?
You give a bolus of a highly osmotic agent that's either mannitol or hypertonic saline.
And how do they work?
They pull fluid out of the brain tissue and into the vasculature. It rapidly but transiently reduces brain bulk and lowers the ICP while you prepare for imaging or surgery.
Once in the ICU, management is guided by direct monitoring. What are the strict targets we're aiming for with ICP and CPP?
We need continuous monitoring. That's usually via an ICP bolt or, even better, an external ventricular drain, or EVD, because that also allows you to therapeutically drain CSF.
And the targets are non-negotiable.
Non-negotiable. Sustained ICP must be kept below 20 millimilli Hg, and we have to maintain a cerebral perfusion pressure, or CPP, of greater than 60 millimilli Hg.
So if we accept that autoregulation is shot, how do we manipulate the systemic physiology to hit those targets?
We use controlled ventilation to keep the PaCO2 in the low normal range, around 4.5 to 5.0 kPa. That helps keep the vessels slightly constricted and the ICP down. We need high oxygenation, so a PaO2 over 11 kPa.
And what about blood pressure?
Crucially, to maintain that CPP of over 60 against a potentially rising ICP, we have to keep the MAP high. That's typically between 80 and 90 millimilli Hg and often requires vasopressors to achieve.
Now, before we start using powerful drugs, what are the simple nursing measures that can help optimize venous drainage from the head?
First, elevate the head of the bed to about 30 degrees. That promotes venous outflow. Also, making sure the cervical collar isn't too tight as long as C-spine stability is maintained is important to prevent jugular venous compression.
And we also have to aggressively treat fever and seizures.
Absolutely. Both of those dramatically increase the brain's metabolic rate and hence its blood flow requirements, which will spike the ICP.
Now, when all those simple measures fail, we escalate to advanced interventions like a therapeutic hypothermia or a barbiturate coma. What's the evidence base for these measures when it comes to long-term outcome?
The evidence is surprisingly limited. While these advanced interventions like increasing sedation, paralyzing the patient, using muscle relaxants, inducing a barbiturate coma with thiopentone, or even performing a surgical decompressive craniotomy,
They are very effective at lowering the number, the ICP.
they are very effective at physically lowering the ICP in the short term. But the source material notes that the evidence for a sustained benefit on long-term neurological outcome is mixed or in some cases absent.
So these are really tools of last resort.
They are tools of last resort to prevent immediate death from herniation. Hashtag 5.3 systemic issues and sequelae.
One of the most challenging aspects of ICU management is dealing with the endocrine chaos that TBI causes, especially the pituitary and hypothalamic dysfunction that leads to electrolyte imbalance.
Electrolyte imbalances, specifically sodium dysregulation, are common, and they're incredibly dangerous because a low serum osmotic pressure will exacerbate brain swelling. TBI can completely disrupt antidiuretic hormone or ADH regulation.
And that leads to a triad of potential issues. Let's nail down the critical differences between cerebral salt wasting, CSW, and the syndrome of inappropriate antidiuretic hormone, SIADH.
Okay, this is key. They both cause hyponatremia, low sodium, but for completely opposite reasons, and they require opposite treatments.
So let's start with SIADH.
With SIADH, the body is producing too much ADH. It's holding onto water inappropriately. So the patient is euvolemic or hypervolemic, meaning they're waterlogged and their sodium is diluted.
And the treatment is to restrict their fluid.
Right. Now, conversely, with cerebral salt wasting, CSW, the brain releases natriuretic peptides, which cause the kidneys to actively dump sodium and water.
So the patient is volume depleted.
Precisely. They are dry and they have low sodium. So the treatment is the opposite. You have to give them aggressive volume replacement with high salt fluids, like hypertonic saline. Getting that wrong is incredibly dangerous.
And the diagnosis of those two and diabetes insipidus, or DI, dictates the immediate fluid strategy, which is why there's a major warning about avoiding certain types of fluids.
Absolutely. There is a critical warning. Hypotonic fluids, like 5% dextrose or half normal saline, must be strictly avoided.
Why?
Because a low serum osmotic pressure will drive water into the swollen brain, accelerating the edema. We aim to keep the serum sodium above 140 millimol using isotonic or hypertonic fluid.
And then historically, steroids were used for swelling, but the evidence is now conclusive against them.
Routine administration of corticosteroids in severe head injury is actively associated with increased mortality. It is therefore strongly not recommended by guidelines. Their only use is to replace specific endocrine deficits if they're found during evaluation.
Seizures are another major complication, especially in high-risk patients. What are the risk factors that would mandate prophylactic medication?
The risk is substantial. It can be up to 60% in those with severe risk factors. We worry particularly about patients with an intracerebral hemorrhage, a depressed skull fracture, or any kind of dural tear.
And what do we use?
Prophylactic antiepileptic drugs, typically phenytoin or levetiracetam, are used early in these high-risk individuals to prevent seizures from happening.
And finally, nutrition. The body needs fuel to heal, and the source material provides a strict timeline.
TBI is a hypermetabolic state. The body is burning through energy. Enteral nutrition, so feeding via the gut, is preferred, and it must be commenced within 72 hours of the injury.
And early feeding is associated with better outcomes.
It is. Delays increase the risk of infectious complications and poor recovery.
Now, we quantify recovery using the Glasgow Outcome Scale, or GOS. It's really crucial to understand what good recovery, a GOS of 5, actually means.
GOS 5 means the patient is independent. They can potentially return to work or school. But it is essential to emphasize that GOS 5 does not mean a full return to their pre-injury baseline.
So even the best outcome isn't a perfect outcome.
Far from it. Many of these patients are left with chronic, often invisible, cognitive, emotional, and personality deficits that profoundly impact their lives and their families' lives for years to come.
The physiological rules change again when we move to the pediatric population. TBI in children presents a whole host of unique challenges, both in assessment and in management.
They are anatomically and physiologically completely different. Children have much larger heads relative to their body size,
Which means greater rotational forces on impact.
and that predisposes them to cervical spine injury and severe acceleration-deceleration injuries like DAI. And of course, assessment is far harder. You can't rely on standard cooperation from a toddler.
For infants, though, there is one direct physical assessment technique that can bypass the difficulty of a GCS.
In infants with open sutures, you can palpate the fontanelle. This gives you a direct, albeit subjective, assessment of the ICP. A bulging tense fontanelle is a clear sign of raised intracranial pressure.
And the GCS itself has to be adapted for those who are pre-verbal.
Yes, the pediatric GCS is required for children under 2. The motor and eye scores are consistent, but the verbal score adapts to reflect age-appropriate communication.
So what does that look like?
Instead of orientated, you have categories like coos babbles, and instead of inappropriate words, you have irritable cries. It's tailored to their developmental stage.
In all cases of pediatric TBI, especially with infants, the index of suspicion has to be exceptionally high for non-accidental injury, or NAI.
This is a professional and an ethical necessity. We must always consider NAI, particularly in young children and infants.
What are the key indicators you're looking for?
You're looking for injuries of disparate ages, which means they occurred at different times. The presence of retinal hemorrhages is a huge red flag. Bilateral chronic subdural hematomas, multiple skull fractures.
Or a neurological injury without a convincing story.
Exactly. A severe neurological injury, like DAI, that occurs without corresponding external signs of trauma. And you have to ask, does the reported mechanism of injury actually match the child's developmental stage? Does the story make sense? Hashtag 6.2 pediatric CT indications, NCE.
The threshold for scanning children is necessarily lower than for adults because of all these factors. What are the specific NICE criteria for CT imaging in the pediatric population?
An immediate CT is indicated for any suspicion of NAI. Also, for the child's first seizure after a trauma, a GCS of less than 14 or less than 15 in children under 1 year old, signs of a basal skull fracture or any focal neurological deficit.
And there's a unique factor for infants under 1.
Yes. For an infant under 1, the size of the external injury is critical. A bruise, swelling, or laceration that is greater than 5 centimeters is also an immediate indication for a scan.
That 5-centimeter criterion really highlights the immense physiological difference. Why is that external sign so significant in an infant?
Because children with open cranial sutures can bleed an astonishing volume of blood into the subgaleal space. That's the space between the scalp and the skull.
Which is effectively an extension of the intracranial volume.
It is. And that volume loss can be so profound it leads to hemorrhagic shock and severe hypotension, which, as we've established, is absolutely lethal to the traumatized brain.
So the management has to be aggressive.
Moderate and severe pediatric TBI must be managed aggressively via ATLS protocols with immediate transfer to a specialist ICU. The focus is always on optimizing cerebral perfusion and oxygenation to combat that secondary injury, just as we do in adults, but always recognizing their heightened physiological fragility.
We have completed our deep dive into traumatic brain injury, extracting the critical information you need for systematic management. Let's just distill those core concepts into the most memorable takeaways for your revision.
Okay, takeaway one. The core of neurotrauma management is the relentless mathematical pursuit of adequate flow. CPP equals MAP minus ICP. You're always actively regulating the MAP to compensate for the pathological rise in ICP.
Takeaway two. You have to be fluent in recognizing the two major life or death pathologies. The warning sign of impending doom is uncal herniation, and you see that as the ipsilateral fixed and dilated pupil.
And you must be able to visually distinguish the two emergency bleeds on a CT scan. The lentiform, biconvex EDH, that's often arterial, associated with the lucid interval, and has good prognosis if you catch it.
Versus the diffuse crescent-shaped ASH. That's usually venous, associated with massive underlying primary brain injury, and has a much more guarded prognosis.
And finally, takeaway three. Strict adherence to systematic protocols is your only defense against secondary injury. Know your NICE criteria for imaging and discharge cold. Be systematic with your GCET components, and never ever forget the most reversible and dangerous insult: hypoglycemia.
Keep ICP below 20 mmHg and CPP above 60 mmHg. Those are the numbers that matter. So, what does this deep dive mean when we step back from the ICU? We've established that even the very best outcome, a GOS of 5, good recovery, doesn't guarantee the patient returns to their pre-injury baseline. It leaves countless individuals grappling with chronic, invisible cognitive and emotional deficits.
So given that reality, where the long-term cost of society is measured in these altered lives and lost potential, not just in the immediate medical expenses, the priority seems obvious.
So here's our final thought. How should long-term multidisciplinary rehabilitation, which addresses the profound cognitive, emotional, and physical sequelae of TBI, be fundamentally reimagined, prioritized, and funded to genuinely acknowledge the persistent, lifelong burden of this injury, rather than simply focusing on the acute survival phase?
That is a question that requires answers far beyond the surgical ward.
A critical thought indeed. Thank you for diving deep with us today. We hope this synthesis proves to be an indispensable tool for your practice.
We'll catch you next time for another deep dive into the core knowledge that matters.